Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. All right, welcome back to the Equine Vet Connect podcast. I'm Dan Carter. We're here at Countryside Equine Hospital. I've got Dr. Caitlyn McCaulley with me.
Yep.
Back in the studio on treatment room 1 here.
Dan's room.
Yeah, Dan's land, as they call it. So we got a couple treatment rooms up here, and this is the one I work in. So they always call this Dan's land, and then
We got the girls' room across the way. So we need to get a neon sign in there that says like girls only.
I mean, we should do that.
We should. It'd be funny.
Add something to the ambiance of the place.
Yeah.
Dan's land. I want one.
Okay.
It's Dan's land.
You can have one. We'll get one. You'll get one. It'll be great.
Neon signs everywhere. All right. Well, today we're going to talk about EPM.
Yep.
This is probably one of our most requested topics.
Yes.
Equine Protozoal Myeloencephalitis.
Mm-hmm. Or as my non-horsey fiance calls it, Equine Possum Malfunction is how he remembers it. So
Yeah, I think that's a great term. The old possum disease.
Yeah. Yep. Yep. So it is very common in the Southeast.
It's a North American disease, by the way, because we have the possum.
We do have the possum, but here in the Southeast, it's got a very high prevalence. They always taught us around 85% of horses in the Southeast are going to be what we call seropositive for the disease, which we'll talk about what that means. But it's very common. We diagnose it a lot. We test for it a lot. And it's something that we see really often. So it's a good topic to cover.
Yeah, in the regional significance of this is interesting because I've got a good friend of mine. She's a vet in Colorado, and we were talking about EPM, and we were talking about Panazaril, things like that. And she's like, "I've actually never bought Panazaril."
Really?
Like she's never had to buy it.
Yeah.
But she's in the mountains of Colorado, and I've lived there. There's no possums.
Yeah.
So
yeah,
that's what she deals with.
It's very interesting. The disease, kind of like the pathogenesis or the life cycle of it is interesting. There's several kind of key players that play a role in the disease transmission, and the horses are what we call an aberrant host or a dead end host. So they're not supposed to be a part of the life cycle, but they pick up this protozoa from possum feces, and so they often get it from water sources, feed sources, places that the possums are hanging around, and it gets into the horses. It doesn't complete its life cycle the way that it's supposed to, so it just kind of gets stuck in the horse and causes the clinical signs that we see.
And that's the other interesting thing, like different protozoa, like we talked earlier about harbor seals.
Mm-hmm.
Harbor seals carry a completely different type of Sarcocystis neurona.
Mm-hmm. Yeah, so the protozoa is typically Sarcocystis neurona is the most common. The other one is Neospora, and then Dan has to say the second word.
Neospora hugasii.
Yes, thank you.
It's one of the few things I can say that's complicated with a Georgia accent and get it out.
I can't with that one. I should say a lot of other complicated things, but for some reason that one just like gets me.
Yeah, so S. neurona.
Yep.
We're going to talk about that. S. neurona is actually what is the name of this protozoa.
Yeah.
So S. neurona, that's what we're looking at. These are, when we say SAGs, we mean that surface antigen. Mm-hmm. And like I said, the S. neurona that affects harbor seals has got different surface antigens than the ones that affect horses. Mm-hmm. So the SAG that we use, that's the ones that is more typically found in horses. That's SAG 3, 4,
yeah,
5.
2, 3, 4.
2, 3, 4. Sorry, SAG 2, 3.
That's okay.
Got
it. I can see the little test box in my brain.
I haven't checked that in a while. So
That's okay.
Usually does that.
I just did one last week, so That's fine. But really, the way it's supposed to happen, it's supposed to go from the intermediate host is skunks, armadillos, domestic cats have been implicated, raccoons, and then interestingly, sea otters and harbor seals can get this as well. But the protozoa goes and it infects their muscles, and then the possum comes along and eats those infected muscle tissues, and then it completes its life cycle, and the possum poops it out, and then that's when horses pick it up.
Correct.
Yeah.
And that's important to remember, too, is because this is a question that gets asked a lot.
Mm-hmm.
horses are a dead-end host. I mean, it gets there, it's not supposed to be there. Well, there's no transmission horse to horse.
No.
So if your horse does have EPM, or if there's an EPM horse in the barn, or your neighbor's horse has EPM, or you're sharing a pasture with a horse with EPM, it's not going to pass horse to horse. It's not supposed to be there. It just goes there, causes problems, but it can't do anything. It's not infectious horse to horse.
Right. And a lot of people will ask, like, okay, well, if one horse on the farm has it, does everybody on the farm have it? Not necessarily. So they obviously are in the same environment, and they could have picked up the same water sources or the same feed sources, but that does not mean that if you have one horse positive for EPM, every horse on the farm then needs to be treated. It's really a case-by-case basis, and really, we'll talk about this as we get into diagnosis and treatment, but just because a horse has been exposed to EPM does not necessarily mean you need to treat them. So it's not one that we go and blanket treat everybody.
Yeah, so let's go back to this life cycle, because I think it's important when you're going to talk about, when we get into disease prevention and trying to minimize your risk. I think it's important to understand the life cycle of parasites in general, which it is a protozoa, but it falls into that parasite category. So again, that sort of reservoir. A reservoir is birds.
Yep.
So that what a reservoir is they kind of maintain this. From there, like you were talking about, getting into the intermediate host. So those are your skunks, armadillos, and that's important because I think back, I can remember when this was really prevalent in Florida and really prevalent in more of the Gulf Coast region.
Yeah.
And then what we've seen over time is this, it seems like it's moving further and further north. But I can also remember when people said armadillos would never come up out of South Georgia. They would never come into Middle Georgia because they don't like clay.
Yeah.
I'm here to tell you, drive down the road, armadillos have adapted well.
Yeah.
They're everywhere. And so that host, that intermediate host, before the possum gets it is very important, because like I said, they're the ones that also harbor this infection that then pass it to the possum.
Right.
So
yeah, they're required. An intermediate host is required for the life cycle to complete itself. So it can't go straight from the bird to the possum to the horse. It has to go bird, intermediate host, possum, and then the horse, like we said, is just an aberrant or dead end host, which gets thrown into the mix.
But and you think about that whole life cycle. It has to go through multiple species.
Yes.
Without multiple species, it doesn't survive.
Yeah. And the protozoa itself is really, actually, the life cycle of itself is very interesting. It goes through both asexual and sexual reproduction, which is very interesting. It's just it's a funny little thing.
Protozoa, yeah.
Yeah. Yeah, when it gets into its normal host, it goes into the muscle. In horses, it doesn't do that. It's very rarely do we ever find anything in the muscle, and it's not its infective stage. Where it goes in the horse is the spinal cord and the nervous system is where we find it in horses, and so that leads to our clinical signs, and which we'll get into. But again, the horse is not where it's supposed to be, so it doesn't do its normal thing in the horse. It causes some other clinical signs.
Right, and you have to have all of these stages. You've got to have the intermediate host. You've got to have the possum. If you miss any of those, so when we start talking about control and minimize environmental exposure, there's multiple places we have to focus on that.
Yep.
So, and one of the things let's talk about is, what is EPM? Yeah. What happens? Like, so we got this protozoa. It's gotten to our horse. A lot of them do manage to clear the infection. We'll get into that later. But when it does actually get into the central nervous system, this is when things go haywire.
Yeah. It can cause malacia or softening of your nervous tissue. It can cause, it causes a big inflammatory reaction, actually, because the body's trying to clear it. So the immune system tries to clear that and tries to get it out of there, but it makes a big inflammatory reaction. And the protozoa can set up shop wherever it wants. So brainstem, spinal cord, the whole way down. It can, very rarely does it actually go to the brain itself.
But it can.
But anywhere in that CNS or that central nervous system is fair game for this.
It's actually been found on some of the larger peripheral nerves as well. So these bigger peripheral nerves, when they've exited the spinal cord, we found it there.
Yeah.
So,
Yeah.
and this is confirmed, like, the way they found this was looking at histopath of spinal cords and like, what the heck is this? And they found this protozoa encysted in the spinal cord.
Yeah.
And then they had to start tracing it back and find out where it came from. So yeah, it can affect it. And it has this affinity for nervous tissue for whatever reason.
Which is so strange because it doesn't go to the nervous system in any of its other life cycle. So it's
No other species.
yeah, it's just weird.
The horse.
Yeah. But horses do things differently, as we know. So
And so that's going to set us up for what you would see your clinical signs, which is going to be a neurologic disorder.
right. In school, they teach you the triple A's. So they teach you asymmetry, so one side more affected than the other, atrophy or loss of muscle tissue, and then ataxia or like the drunk walk. In the real world, outside of your lecture slides, it can look like anything. Like, I mean, it does whatever it wants. Like I said, it can set up shop wherever it wants in the nervous system. And so it can lead to a multitude of clinical signs that we have to then pick through and say, okay, is this the other 20 things that cause neurologic disease, or is this EPM?
Well, and I think that gets in neurology, which I'll be honest, when I first started vet school, neurology intimidated me.
Oh, it's a
I was
lot.
terrified of it. And then after getting out, and I had the pleasure of working with Dr. Stephen Reed, who wrote the book Equine Neurology. He was one of the vets that helped train me when I was in Kentucky, and he kind of fostered this love of neurology, like because once you found out really how simple it is, and it's an absolutely, the simplicity is what makes it so beautiful, I guess.
Yeah.
Like I love neuro.
I just remember learning neuro and I was like having an existential crisis because my brain is trying to learn how the brain learns. And I was like, what?
Well, once I figured out it's a wiring system,
It
like
is.
everybody, like if you break neuro down into its simplest form, it's a wiring system. It's the wiring system that makes the body work. You've got big ones and you got little ones. And so figuring out which one of those it is really critical.
Yeah.
So you got to understand upper versus lower motor neuron. And then it's a matter of figuring out where the issue with the wiring system is.
Localization.
So
Yep.
you always say, like, if your toaster doesn't work, is the problem in the toaster? Is it in the cord going to the outlet? Is the problem in the outlet? Or is the power off to the whole neighborhood?
Yeah.
And so that's what we're doing. We're doing these neuro exams, is finding out where the power is no longer working.
Yep. But again, they teach you those 3 A's in the ivory tower, but it doesn't look like that in real world. I've diagnosed it from a horse that ended up lacerating its head in the trailer and then she got here to get it stitched up and she's like, oh, like he's been stumbling a lot in the trailer and he keeps rubbing the hair off of this same spot every time I haul him. And then he tripped on the trail with me once and I'm like, maybe should test him. He was positive. I diagnosed it in a mule that just didn't have any kind of power or propulsion behind. And I got there and I looked at him and I was like, yeah, probably need to test him. He was positive. So it can be very subtle things. And if we pick it up earlier before that neurologic disease progresses, we often have a better chance at getting a full recovery.
Because a lot of times it can progress as a change in mentation or a change in behavior. Because if it is affecting the brain, it will cause changes in behavior. Sometimes it can be very severe where they're like stumbling every which way. Sometimes it's just subtle issues with placement of the limbs, what we call proprioceptive deficits. I always like to say proprioception's I always compare it to a DUI test. It's how you can close your eyes and touch your nose without seeing either one, or you can put your 2 fingers together because your body knows where everything is in space.
Right.
And that's usually one of the first things we see is a loss of that proprioception. They're not quite sure where their feet are.
And to test that in horses, there's a couple things we can do. One of the things is that we basically lift their head and ask them to walk. And so we're taking away those normal visual cues. We're asking them to walk straight forward normally without all of those extra sensory inputs to know where I am in space. And then you can also blindfold them to really take away that sensory input. We can do limb placement tests where we take a front limb or a back limb and we either cross it over the other leg and ask them and see how long it takes them to appropriately place it back, or we can abduct it or pull it away from the body and ask them to put it back. So those are some ways that we can test it. We can take them up and down hills. We can walk them over a curb if you have one. But those are all the different ways that we can test proprioception in horses. And
Working circles, big, little.
Yeah.
How do they place their legs?
Yep.
Tail pulls,
Yep.
just for weakness.
Yep.
So when your vet comes out to look at this, you're going to see them do a lot of different testing. But what they're trying to figure out, what part of the neuro system's involved,
Mm-hmm.
and then where at in that neuro system it is.
Right.
So like I had one that was a left-sided facial paralysis.
Mm-hmm.
And interesting enough, it ended up being positive for EPM, and it was actually affecting just that cranial nerve after it exited the brainstem.
Yep.
It was on that peripheral nerve, complete left-sided paralysis. Once we treated it, a lot of that function came back.
Right. Yeah, and you can see facial nerve paralysis and like a muzzle droop and eyelid. They're not blinking appropriately. Sometimes they get dysphasic when they can't swallow appropriately. Yep. Like we can have a lot of problems with EPM, but it's just, again, where in the nervous system is that protozoa hiding, and what havoc is it wreaking?
And we're going to talk about this a bit later, but that neuro exam is so critically important, not just for getting a diagnosis, but also monitoring treatment. Mm-hmm. Because that is our best tool. Yep. And that's one of the things I warn people is we're going to come in here and do a neuro test, and we decide your horse is ataxic or it has a neurologic disorder. Mm-hmm. We diagnose them with EPM. Well, one of the things we're going to do is we're going to monitor throughout treatment on how they're improving. Yep. And so I always caution people, don't practice these tests at home.
Yeah.
Because your horse can learn.
Yeah.
They will learn how to pass the test.
They're very smart.
So, and that's one of the things I tell you is like, you don't need to be doing this every week. Like, save this for us because that's how we're going to monitor our success.
Right. Get your baseline. So, when you're walking them in and out of the pasture or the stall, like, how do they look to you? Do they look stronger? Are they more stable looking? But don't do our tests. Let us do our tests.
Yes. Because like I said, they may throw off how well we think treatment's going.
Mm-hmm. Yeah.
So that's a big one for
you. Yeah, that's fair.
So
but yeah, it can look like anything. It can be very subtle. It's usually a disease that kind of comes on slowly and progresses slowly, but it can also come on kind of hard and fast and be acute. So it can really look like a lot of other things. And so that's where we come in with our neuro exam to kind of pair this out and figure out what exactly we've got going on.
So then this is where the debate really gets started. Okay, so we've got a horse that's neurologic.
Yep.
We need to start doing testing.
Mm-hmm.
And I feel like this is where, like, you're in one camp or the other.
Oh, yeah.
I mean, which test you like?
People have strong feelings.
Yes, I like an ELISA test. I like the SAG 234 ELISA.
Yep. So that test is, we can go back to our lovely immunology. That is testing a surface protein or surface antigen on the protozoa, and it's testing for the antibodies that the body makes against that antigen. So you have to, in order to use that test, the horse has to see the protozoa, make an immune response against it, make those antibodies against it, and that can take up to 2 weeks. So if you have a really acute disease and you haven't had enough time, might not be perfect.
And I've seen that more than once.
Yes. Yep. So you have to keep that in mind.
And that's something to remember. All the tests we're going to talk about, they're all antibody tests.
Correct.
And so really and truly, we're saying there has been exposure and we build an immune response. Mm-hmm. It is not a concrete diagnosis.
Correct.
It is not that's always the issue when you're dealing with antibody tests. Mm-hmm. Because like you said at the beginning of the podcast, the vast majority of horses will become infected with this protozoa and then they'll clear it.
Right.
And it will never enter the central nervous system. So we're going to find those antigens or those antibodies in about every horse.
Yep.
So this is where the interpretation of a neuro exam, clinical signs, and testing are going to play a role.
Just because they're seropositive on a test does not mean that they are clinically infected.
Correct.
It means exposure. So just make that clear. And that's why we said it's not a blanket one that you go and just treat everybody or you test everybody.
Right.
If they're not clinical, I'm not going to test them.
Right.
Yeah.
So the ELISA is one way. Mm-hmm. The enzyme-linked immunoassay is one way we can test. Another test that it's probably one of the original tests, I guess, was the IFAT, immunofluorescent antibody test. Yep. This was done mostly, I think UC Davis is the only one doing it. Mm-hmm. But it's another way to look at antibodies, but it looks at them through a different different test.
A different test, yeah. But again, it's all antibodies, so they have to be exposed, and the body has to mount that antibody or immune response. The gold standard is to get both blood or serum and cerebrospinal fluid, or the fluid that bathes your nervous system, and compare those ratios of antibodies to say, are we exposed, or do we actually have, the thought process is if you have a higher antibody concentration in the CSF fluid, then that's more indicative of an infection. Not, again, it's not concrete, but it's more indicative of an infection actively.
And getting CSF, there's 2 spots we get that from. We can do what's called a lumbosacral tap, which is back by the hip. More recently, we've been doing ultrasound guided AO taps. So this is up just behind the base of the skull. We can visualize the spinal cord, and we can collect some of that CS from the atlanto-occipital AO joint.
Yep.
So 2 different sites that can be gotten.
Yeah.
I'd say the large majority are done off of blood tests and clinical signs.
Yeah. The CSF taps are, I wouldn't say they're super difficult to do, but they have some risks and things that we have to minimize. And I've not done one. I've done all of mine off of serum. So
I've done all of them over the years.
Yeah.
I've done them all. I've done LS taps. I've done standing AO taps. The bulk of the time I'm looking at serum.
Yeah.
I feel like if I need further clarification, I may reach for the paired serology and CSF, but the bulk of the ones I do, I'm going to do off serum.
Yeah. Yeah, because a lot of times they're clinical enough, and again, I'm not going to test them unless they're clinical.
Right.
And if I have those strong clinical signs paired with a positive serum antibody test, then I'm going to say that's enough for me in this region, because it's so prevalent.
Right. But I think the most important takeaway from this is it's not just a yes/no off of a blood test.
Correct.
And it's not just a yes/no off of blood and paired CSF test.
Yeah.
You have got to have those clinical signs. You've got to have that neurologic evaluation.
Yeah.
If you don't have that, your test is a pretty piece of paper.
Yeah.
Because I've had horses that had high titers, but without neurologic symptoms. So that tells me we've had exposure.
And we've mounted a really good antibody response.
But I'm not seeing signs of clinical disease.
Right. Yeah. There's the interpretation is a really big part of this disease, and that's why we come in and, again, help figure out exactly what's going on and make the best course of treatment, because the treatment for this disease is not low cost.
It's not. And the good news is it's very, I hate to use the word safe, but it's a very low risk as far as the treatment, but it is a high cost.
It is. But again, it's the way that the testing works and the interpretation works, I explain it to people, it kind of comes back in like a sliding scale.
Right.
And so you have like a low ratio, which is negative or low exposure, and then, or you can have a high titer, which is more indicative. Again, more indicative.
More indicative. Again, it has to be paired with a neurologic evaluation.
Yeah, but it is kind of like a sliding scale, and so we can look at the number that comes back and look at the clinical signs and the clinical picture, and we can make a recommendation based on those things. So
correct. So it's important, if you suspect this, talk with your veterinarian, because like I said, clinical exam is really, really important here. Getting the testing done is also very important. And everybody's got their tests they like. Like I said, I'm a big ELISA guy. Some people still like the IFATs. All right, so we found out your horse does have EPM.
Yep.
Now let's talk about treatment. And I think this is where people have very strong opinions. This is where you can kind of we can kind of dive off into the voodoo here. And so again, this is going to be straight facts, stuff we knows work.
Yep.
We know works, and we're not going to get into voodoo. We're going to tell you what is voodoo, in fact.
Yeah.
So a big thing for me, I like to call them the reels. Pinazaryl and diclazaril. Like the reels are very, very, very effective.
Yes.
At treating this.
Yes, they are the only FDA approved treatments for EPM, and they do work. Your Pinazaryl is your Marquis paste. That's the brand name of it. And we give it kind of like in a loading dose the first day, and then we go to get up to therapeutic levels in the bloodstream, and then we go to kind of like your maintenance treatment
Daily
dose. Yeah. Diclazaril is your Panazaril pellets.
No, diclazaril is your protozoal pellets.
Protozoal.
Hey, you went to Panazaril pellets. You got.
I always do that. I do that every time. I say diclazaril is Protozoal, but it's not.
No.
Anyway.
Yeah, diclazaril is protozoal.
Yes.
So it's a cousin. They're both reals.
I do that every time.
Yeah.
But yeah, those two are Protozoal pellets, and they work. They are easy. They're pretty palatable. So people have their preferences on the paste or the pellets. It's really, for me, it's a little bit about cost, and then also about, is this horse easy to dose with a paste?
Right.
Or do we need to go for a pellet because they're terrible for oral meds? Or just kind of, it's a case by case thing. But they both are very effective.
Yeah, I like both of them. The Marquis is great because if they're good for oral meds, if you put the paste directly in the mouth, you wipe it swallow, you know they got it. If your horse is like, no, I'm going to fight you, not the med we need to use. Yeah. And so when I do use the Protozoal, I tell people, like, you want to make sure they eat it. Like a little bit of feed in the bucket, put the Protozoal in, watch them consume it. When that's gone, they can have the rest of their feed. Yeah. Because horses like to drop grain. Some horses just won't eat it.
They're also very nimble with their little lips, and they can like pick around stuff. And
I have literally seen them eat all the grain out of a bucket, and the Protozoal still be left in the bucket.
Yeah, they're very good.
You want to make sure they actually eat the Protozoal because medication in the bucket does not help us. Medication must get into the horse.
Intra-horse, yes.
Intra-horse.
Yes. So those are our two mainstays of treatment for this gun. The other treatment is a combination of sulfadiazine and I'm gonna butcher it every time. Pyrimethamine, there we go.
Yeah, pyrimethamine.
Yeah, I can't say them when they have so many consonants. It just gets me.
So for all listeners out there, if y'all have trouble with this, just remember this is our job, and we still have trouble with some of these words, so it's okay.
They're very large.
We're going to call this Rebalance. Yes, that's the brand name of it. We're going to call it Rebalance.
That's easy.
So, yep, it's basically a sulfa-type treatment. It's actually one of the first treatments. It's an older treatment. It's one of the first ones we had before we had the brills. Yep. And it's actually coming back into favor a little bit. So
I've used it too after you use your reels, like you can kind of finish them off with this combination for the Rebalance. And so I've used it that way too. The biggest thing, which this was a new thing for me that I learned, you're supposed to give it either an hour before or an hour after you feed hay, because there's dietary inhibition of folate, which can lead to anemia and panleukopenia, which I didn't know. So you learn something new every day.
It is important because that's one of the things that if you're going to use the Rebalance, I tell people we need to be diligent about checking those CBCs. Every few weeks we need to be watching those CBCs because you can get that panleukopenia or that low white count across the board. And that low white count will set us up for risk of other infections. Plus, it's not helping our body. We need the white blood cells to go help us get rid of this parasite. Yeah. So that is something we have to watch as we go through for treating with the Rebalance. Yeah. It's rare. I think I've seen one case on long-term sulfa use. I've seen one case that actually got the anemia and the panleukopenia, and that was one time. So it's not terribly common, but it's something you need to be aware of.
Yeah. Other things that we'll do when we're treating a horse for EPM, I pretty much always put them concurrently on a vitamin E supplement.
Yes. Vitamin E is the most potent antioxidant in the nervous system. Yes. And when you have EPM, you have a lot of oxidation, a lot of free radicals being produced. Vitamin E is the most potent antioxidant we have.
Yeah. And it does matter which vitamin E supplement you choose. Yeah. They are not all created equal. So the two that we recommend most times are either Nano E, the liquid, or the Elevate E powder is a good second.
I'm real big on Nano E in these cases because studies have shown where we can be at steady state in the central nervous system within 7 days.
Which is huge.
Huge.
Yeah.
When you're looking at the acetated form or the Elevate, it's a vitamin E acetate. it's going to take about 56 days to get to the same place. We don't have 56 days when we're dealing with a narrow case.
Yeah.
So we need to get there. We need to have that high dose of vitamin E quickly. So this is one time I get really particular. I want nano E.
Yeah.
And I want a really high dose of nano E. Like usually we're somewhere in that, depending on the size of your horse, somewhere between 5,000 and 7,000 IUs.
Yeah.
We need a lot of vitamin E on board.
We need it quick.
Yes.
Yeah. The other thing, we use it to kind of like boost the immune system is levamisole. It's we use it as an immunomodulator, so sometimes we'll throw that one in there.
And that's an interesting one because it's actually a porcine or a pig dewormer, but for whatever reason, it has these immunomodulatory effects in horses.
Yeah.
So it's kind of we add that in. It's a pretty cool thing. So.
Yeah.
And when you're treating these, like a lot of times we're on one of these, or we may be on several different ones. Like there's a lot of things. That's why it's really important to work with your vet and figure out, through their experience and through what we're finding research wise, you're going to be on kind of a cocktail. So
yeah, and figuring out what works.
One other thing I want to talk about treatment wise, and this one will set
into it.
Oh, I'm gonna jump right in. Well, we're gonna jump into that too, but the one I want to talk about is DMSO.
Oh yeah.
So DMSO again, it scavenges free radicals. That's an issue. It has a neuroprotectant, and this will split veterinarians down the board. There's only two kinds of veterinarians. Those that think DMSO solves every problem, and those that think it is snake oil, hate it, get rid of it.
See, but I came from one Carter to the next, so I'm a DMSO girly.
I'm a DMSO guy. I mean, Steve Reeves is a DMSO guy.
Yeah.
So he's the godfather of neurology. I'm going to listen to him.
Yeah.
So yeah, DMSO, your vet will talk to you about that. We put it in, usually we mix it in with a 5-liter bag. There's a dose, a certain concentration you have to run. We're giving them to them twice a day. It's usually used in the acute phase of treatment. Like if we're really neurologic, we're having severe clinical signs, we're getting that on board right away.
Yep. I do tell people to, as we are treating this disease and inevitably kind of killing off that protozoa, we can incite an inflammatory response, and the nervous system does not like inflammation, and so they can get worse. Usually it's within the first 2 weeks of treatment that can get worse. And so I caution people with that, and I'm like, if that happens, let me know, because there's things that we can do to kind of mitigate that, but don't give up. Like if that's happening, we've got to just keep on. We've got to keep treating.
We just need to add a few other things in, because we didn't really get into this, but we grade ataxia in different grades. 1 being mildly affected, 5 being completely recumbent.
Right.
And I've definitely had some that were sitting on a 1-2, and then they end up in that 3-4 range shortly after, once we start treatment.
Yep.
Again, we can manage that.
Yep.
But we have to be aware. So if you start treating your horse and you notice them getting worse, 1, take a deep breath. It's okay.
Yep.
2, pick up the phone, call your vet. We need to add some other medications in.
Yep.
So don't be discouraged. Don't be discouraged.
Yeah.
And that's another thing on treatment is we had this, it kind of came out, we treat them with 30 days on marquee and everything's better. It don't work that way.
No.
So I'd say the bulk of the horses I treat, we're somewhere around 60 to 90 days. I'd say the bulk of them are close to that 60 day.
The way that I usually tell people, I'm like, we're going to treat for 30 days. We're going to do a second neuro exam and another evaluation and see where we're at. Usually we'll do another 30 days if needed, and then again, repeat that neuro exam. And yeah, the majority of them down here, we're looking at 2 to 3 months of treatment.
Right. So that's why, again, it's important for that neuro exam, because 30 days after starting treatment, we're going to come back, do that second neuro exam, determine, do we need to continue treatment, or do we need to get into, I call it a maintenance dose or preventative dose. And I guess let's go ahead and jump into that. Depending on which product you're using, if you're using the marquee, that's usually a double dose once a week.
Yep.
If you're using the Protozoal, that's usually 1 dose twice a week, is what the literature's suggesting. And that's after you've completed treatment. Neuro exam's doing great, but we're not ready to come off completely. We'll sort of taper off. So you may be several months on what we call that maintenance or preventative dose.
Yeah.
So.
Yeah. I would say I was reading and it said that, less than 25% of horses make a complete recovery. I don't know. In my experience, I think it's a lot better than that.
That's also some older data.
Yeah,
That's older data. And like I try to tell people, we get better at things.
we do. And the earlier we catch it,
Yes.
the better off we're going to be.
Well, I feel like that's a big part of it. We're catching it faster now than we ever have.
Mhm.
We're aware of it. More people, because it used to be so regional in little pockets, and now that it's gotten more widely distributed, I feel like we're finding this sooner. Owners are more aware, so they pick up on these subtle things and call the vet.
Mhm.
More vets are aware of it.
Mhm.
And so this early intervention, I think it's probably less than 25% that don't make a full recovery.
That's what I would say as well. You can have relapses, so usually those happen within the first 2 years after completing treatment. So I think it's less than 30% though that will have a full relapse. We don't typically retest them. We don't do we don't pull more blood, or don't do another CSF tap. We go again based off of neurologic exam and clinical signs.
And that has to do with, we're testing titers.
Mm-hmm.
So a titer says, yes, you've been exposed, but it will not tell you if you're being successful in treatment. They don't go down.
No.
And that can even be horse dependent. Some of these horses can have high titers for a very long period of time, years.
Yeah.
But rechecking that titer is really of no help whatsoever.
Yeah, that money and time is better spent towards treatment. So
yeah, treatment neuro exams.
Yeah.
So let's talk about the one treatment out there that, and I'm sure we're going to get a lot of comments on this, but I'm just going to go ahead and jump into it because it really frustrates me.
Go for it.
I think is it Origentin now, or is it Orquin? It's had both names.
I don't know what it is because I don't use it. So
it is a combination of Dequinate and levamisole.
Mm-hmm.
And so
it's touted as a 10-day treatment.
Yes.
Does not work.
No. So the problem is, and so Dequinate was one of the original treatments. So Dequinate is also a coccidiostat or an anti-protozoal. It's used a lot in the poultry industry. So that was one of the original treatments back in the 70s.
Yep.
It has somehow had this revival. But the problem they noticed back in the 70s, it doesn't cross the blood-brain barrier.
So there's in neuroanatomy, there's this fun thing called the BBB, or the blood-brain barrier. It separates the blood from the brain and the nervous system. Only certain drugs cross over that. So like the difference between your Benadryl and your Zyrtec, why Benadryl makes you drowsy and Zyrtec doesn't, it is because Benadryl crosses the blood-brain barrier, Zyrtec doesn't.
Correct.
That's the difference. This medication does not cross the blood-brain barrier, and that's important because the protozoa is across the I can't say it now. The BBB.
Yes. So if the medication cannot cross this blood-brain barrier, it cannot treat the parasite.
Correct.
So Dequinate, it does not work.
And 10 days of treatment for this
does not work.
No.
If your horse gets better on Dequinate, it did not have EPM.
Yeah. It had inflammation.
Yes.
That you have.
Yeah, the levamisole portion we know is an anti-inflammatory.
Yeah.
We know it's an immunomodulator.
Yeah.
But it's not EPM if Dequinate helps it.
Yeah.
And I'm sure we're going to get a lot of hate mail on this.
We're going to get so much hate speech for that.
But it's our podcast, and we said right there in the front, we're going to bust myths.
Yeah, bring it on. Let's go.
So I just want to go ahead and bust this myth right now.
Yeah.
Don't recommend it. Don't sell it. Won't prescribe it. I still don't know how I got a medical use patent, but somehow I did. But we do not utilize it here.
No, we do not.
And don't plan to start.
Yeah, we're science-based and evidence-based, and
yes,
that is not it.
And it says it do not work.
No.
So.
Yeah.
Stick with the reels. That's the bottom line here. You want a reel.
Yeah, the reels really work. So.
Panazaryl, diclazaril. Yep. You want a reel.
Yeah.
Get a reel.
Yeah. So as far as prevention goes, the biggest thing is, we're never gonna be able to completely eliminate possums.
Nope.
We're never going to be able to completely eliminate the intermediate hosts that give it to the possums. But, keeping your water sources and your feed sources especially sealed away from the areas where those animals can get to them is important. That's probably the biggest thing. How do you feel about prevention, like using meds before they're clinical? Like,
So I do have certain situations where I have horses going into endemic areas, like highly endemic areas. I will put them on that maintenance or preventative dose. Used to we did this a lot with our horses when, it used to be really prevalent down in Florida, and a lot of horses that would ship into Florida for the winter, they would actually go on a maintenance dose or a preventative dose of the medication because there was concern that they could pick it up. And the beauty of these medications is they are incredibly safe. Like when you look at the toxicology studies on Marquis, they stopped the study when they're at 15 times the labeled dose, because they're at 15 times the labeled dose, which is a massive amount of Marquis, and they had zero
cannot imagine.
issues. I just feel bad for the poor soul who had to put all that in.
Yeah.
I mean, you're talking a lot of Marquis.
And it tastes terrible.
Yeah, you're talking about 2 full tubes on a
That's
1,000-pound
crazy.
horse.
Yeah, that's nuts.
But when they were doing the toxicity studies on this, when they got to 15 times the label dose and they had zero ill effects, they're like, okay, we're good.
Yeah.
So, because there's what we look at in toxicology, a little segue here, is what's called an LD50, and that's a lethal dose to kill 50% of the population.
Yep.
And unfortunately, the way that's found out is
you get more and you get
more and more and more.
more.
And they never found the LD50 in these.
Yeah.
So it's incredibly safe. So I will utilize it. If I've got horses that we are concerned, if they're going into an endemic area, then we will utilize it.
Yep.
One of the big challenges, I think, is, and we see kind of spikes in this. One of the things I've noticed is when you've got the urbanization of rural areas.
Yep.
Possums, armadillos, skunks, they don't really like people in general. So if they can stay in the woods by themselves, they're fine.
Yeah.
But what I've noticed over the years is when I start to see development around the horse farm, they start building houses. These animals are looking for a place to go. And temporarily they end up at the horse farm.
Yeah.
Because it's at least open land and there's no bulldozers going.
Yeah.
And that's when I will see it. And there have been times when I've got a lot of construction around a farm that we have talked about, do we need to put them on a maintenance or preventative dose, especially if I start to see 1 or 2 cases popping up, and we understand that the farm's doing everything right. It's just they're building all around them.
Yeah.
They eventually, the animals will eventually move on. They're not going to live at the horse farm forever because, like I said, they don't want to be around people.
Right.
But with the housing project going on next door, that's
the next best thing.
Next best place to be. So that's theory according to Dan, which is absolutely useless probably.
I think it tracks.
But it makes sense because I have just noticed over the last 15 years when construction booms, so does EPM. Dan
is very observant and notices patterns, so like it's not nothing.
I'm just saying that's just what I've seen. So, but yeah, so I will utilize it. Are you in that camp?
Yeah, I mean, I don't see a problem with it. I think it can be very helpful. I just haven't really run into it yet, so I haven't been doing this as long as you have.
Well, I get a lot of horses that ship all over the country, and shipping causes increased stress. And then, like I said, going into, we first started doing it when we had a lot of horses shipping to Florida when it was really prevalent down there. Now it's just as prevalent where we're at as it is in Florida. Yeah. So
I think it's important too if you have an animal that's in a non-endemic area and you do move them in, like they can get exposed and they're like, whoa. So yeah, that's.
We have that a lot of people moving here. We have a lot of people from California, the Northwest, and even the Northeast moving to this area. And, when they first encounter EPM, they're like, what is this? And it's like, oh, everybody that lives here.
We're like,
yeah, that's just EPM. I shouldn't say just EPM, but we see it so regular, but,
I think people read about it and it does sound really scary, and it can be really scary, but the majority of the time at this practice, we're catching it so early that we're like, oh, it's going to be okay.
Yeah. Like EPM's kind of like our Lyme. Like I taught my friends that are up in Virginia and in the Northeast, Lyme disease is like a daily thing for them. And, of course, if they see EPM, they're like, what the heck? And if I get that one Lyme positive case, this ships down here and it's Lyme positive, I'm having to pick up the phone, call my friend Jen in Virginia. I was like, hey, so it's been 4 years. What's current, right? Because I haven't kept up on treatment of Lyme because we don't have it down here. Yeah. And so I'm always having to call Miss Jen, like, hey, Jen, what's current treatment for Lyme? What's working? And so same thing, you know, some of my friends that are out in the Northwest, they get a little EPM like, hey Dan, what are y'all doing? So
Yep, but that is equine possum malfunction in a nutshell.
that's in a nutshell. I think we're going to have another episode because there's a lot of other things that we need to get into on this, not just treatment, but you know, rehab's a really important thing.
Yeah.
Some of the other conditions that EPM can cause, some of the neuromuscular diseases. So I think we're going to need to do an EPM round 2 because I do think the rehab coming back from EPM is very, very important.
Because you lose that normal neural function and you lose your muscle tissue too, and we've got to bring them back from that.
So we'll get that one up and going here pretty soon because we kind of touched the surface. So we'll hit on EPM round 2 here shortly. But that is equine possum malfunction in a nutshell. So what would you say? All right, let's go. I always love to do this. What are your key takeaways? What are the things, if you learn nothing else from this, what are your takeaways?
Yeah. My biggest ones would be you've got to have your paired tests in your clinical signs. So, that exam aspect of it is very, very important. It can look like a lot of different things. So definitely getting your vet involved is important. And then, use the treatments that we know work, please.
Yes.
Yeah.
I'm going to agree 100%. Neuro exam. It's like I say this all the time. X-rays without a clinical exam are just pretty pictures.
Yeah.
You've got to have a neuro exam. The examination is the foundation of veterinary medicine and medicine in general all the time because all your ancillary testing is just pretty paper and pretty pictures unless you've got a clinical disease. You've got a clinical exam to tie it to. Yeah. Now we can have clinical disease. So neuro exam, absolutely. Treatment, use the things that work. Be aggressive. And use what we know works.
Yep.
So, all right, we'll get into maybe that'll be one of our next episodes. Let's get into the rest of EPM because I feel like we could probably talk like 8 or 10 podcasts just on EPM. We just scratched the surface on this. So, but thanks for being here today, Casey. Thanks for editing this thing. April, thanks for filming this. We really appreciate it. And thanks to all our listeners out there. We really appreciate y'all tuning in and making this podcast a success. And we'll keep working on getting all the topics. We got a lot of great ones, but unfortunately, this real job makes us have to actually go to work. So,
I mean, I don't think it's unfortunate. But...
I don't think so either. I enjoy it.
Yeah.
So, cool. Well, thanks for tuning in. We'll see y'all next week. Take care.